Welcome to our sonography lecture on abdominal vascular pathology, part 4 of 5. This lecture will cover portal pathology, including portal hypertension and tips. We already covered portal hypertension pretty extensively in the hepatic pathology lecture. So this is going to serve more as a review for these first few slides, and then we'll delve a little bit deeper into the hepatic Doppler protocol. Portal hypertension then is increased blood pressure in the portal system, and this is typically due to some sort of damage to the liver, most often cirrhosis. Some other things that can cause portal hypertension though are blood clots within the portal system, infection of the liver, infection of the pancreas, which can then occlude the portal vein. We might also see some extrinsic compression that would be typically by lymph nodes or masses near or around the liver, or it can be idiopathic. Clinically, these patients are going to present with ascites. They're going to be tired, have weight loss. Their spleen is going to be enlarged because the blood is flowing back into the spleen instead of going through the liver. We might also see esophageal varices, encephalopathy, and caput medusae appear. If you need to review any of these topics, please refer back to our hepatic lecture. On ultrasound, we will see typically a cirrhotic liver, so that is going to be a shrunken liver with those scalloped edges surrounded by ascites. When we use color to evaluate the direction of flow in the portal vein, we will see that it is hepatofugal. Remember that hepatofugal means away from the liver, where hepatopedal means towards the liver. The portal vein is typically dilated with portal hypertension, showing a measurement in the AP direction of greater than 13 to 15 millimeters. And we may also see some recanalization of vessels at the porta hepatis or of the ligamentum teres. Let's take a closer look when somebody is suspected of having portal hypertension, what the protocol looks like to evaluate the portal system flow. We're going to take a walk through the hepatic Doppler protocol. This is just an overview of the protocol. We'll be doing more of this in our small parts lab, where you will see more detailed images and get more hands-on practice. So for the hepatic Doppler protocol, your patient should be NPO for 6 to 8 hours. We are still going to perform a complete normal right upper quadrant or abdomen complete protocol, taking all of our grayscale images. While we are conducting the abdomen protocol, we want to make sure that we are looking for cirrhotic liver changes and any dilated vessels that we'll want to interrogate when we perform the Doppler portion. Some tips and tricks for using color and Doppler while performing a hepatic Doppler protocol are going to be to use the correct window. This is very important. While we are scanning the abdomen, we typically use our curved linear transducer. The curved linear transducer is not able to be steered like we can steer our linear transducers. So we need to use the correct window that gives us the best angle for interrogating the vessels that we're looking at. Physics tells us that we want our angle to be 60 degrees or less, but unfortunately most of the vessels in the abdomen cannot achieve that 60 degrees. However, we usually can find a window that gives us more of a 0-degree angle, which is completely acceptable for abdominal Doppler work. So we want to make sure that we're using either subcostal or intercostal windows that give us the best angles for Doppler, and it's going to depend on each vessel. So you'll want to pay attention to what window you should be using. The next thing you need to know is when should you be using angle correct. A lot of our work will be involving just checking for patency of different veins, but some of them are going to be wanting measurements of the PSV or EDV. So anytime you have to do a velocity measurement, you always should have your angle correct on. Having the angle correct on assures that we are getting an accurate velocity measurement. Finally, when you set up your color map, you want to make sure that you keep red as towards the transducer and blue as away from the transducer. This is the standard setup for most Doppler protocols. And it ensures that we keep the portal vein and the splenic vein at midline in the red designation, which is common for this exam. So again, red on top, blue on the bottom. Don't invert at any point during the exam. To start our hepatic Doppler protocol, we're going to start out at the spleen, looking at the splenic vein at the hilum. The window that you're going to use is a left intercostal window. We're going to see blood flow, normal blood flow, being blue or hepatopetal, flowing towards the liver. You do not need your angle correct on, but when you turn on your Doppler tracing, you'll be evaluating the direction and for any varicosities in the area. We can see in the image here that we have blue vessels and red vessels. The red vessels represent the splenic artery, the blue is representing the splenic vein, flowing away from the spleen towards the midline, showing a steady flow. We're then going to move to the splenic vein at midline. If you recall your anatomy, the splenic vein comes up on the posterior side of the pancreas tail. So as it is coursing posteriorly, it is also coursing anteriorly, showing us then that flow is moving towards the transducer. So the splenic vein is blue at the hilum. It is red when you come to midline, and this is normal. So we again are showing that the splenic vein is coursing towards the portal confluence. It is hepatopetal. Again, we do not need to turn the angle correct on because we are just evaluating for direction and patency at this point. So in the image again here, we can see the pancreas, and we're going to use the pancreas tail as our landmark for identifying the splenic vein as it courses posteriorly and towards the splenic confluence. Now it can get a little tricky in this area because another vessel that you're going to see that typically shows up as red is the splenic artery. You have the aorta here. Quite often we have the celiac axis coming off, and we'll catch part of the splenic artery as it travels towards the spleen. So you want to make sure that you're Dopplering the correct red vessel, looking for the one that's coming deep and coursing anterior. The next stop that we'll want to make then is on the IVC. We are going to use color again to look at the IVC, showing patency and evaluating for pulsatility. This picture tells us, is there any sort of clot that might be in the hepatic veins that has expanded into the IVC that might be causing the portal congestion? So we want to evaluate for patency and pulsatility. Normal flow in the IVC is blue. It is a subcostal window as we watch the blood flow towards the heart. In this image here, we can see the IVC elongated posterior to the liver. Again, we want to angle our vessel so we get a nice color fill, typically showing blue, as it goes towards the right atrium. The waveform that we should obtain then is typically very pulsatile as it is affected by the heart contractions. The next thing that we will evaluate then are all of the hepatic veins. Remember, we have a left, middle, and right hepatic vein. To obtain the left hepatic vein, we are going to use a subcostal window. We are going to find a transverse view of the left lobe of the liver, and we are going to be positioned in between the superior and the caudate lobe. We are going to find the hepatic veins coursing through there. Your best place to sample the hepatic veins is going to be about 1 centimeter or 2 away from the connection to the IVC. Now the middle hepatic vein is going to run through the middle of the liver and can be seen either subcostal or intercostal. Again, you'll want to evaluate which window gives you the best angle for the vessel. And then our right hepatic vein is going to be sampled from an intercostal view. Remember, when you are imaging through the transverse right lobe, it is our second landmark after dome. We move inferiorly to the hepatic veins. If you image that picture from the intercostal, you will have a nice view of the right hepatic vein as it courses towards the transducer. Now, the normal flow in the hepatic veins is usually assigned blue. We should see complete color fill of the hepatic veins as they enter into the IVC. You do not need your angle correct on, as we are only evaluating for pulsatility and patency. In the image here, we can see the sample gate is placed within the hepatic vein, and this is a very typical waveform that we get with hepatic veins. Notice how the W's are on the bottom of the waveform. Next, we're going to work through the main portal vein. To measure the main portal vein, we want to come back to our subcostal window. When we are in the subcostal view, the portal vein will course horizontally across the screen, meaning that it is perpendicular to our ultrasound beams. This gives us the best area to measure the portal vein. Remember, it should measure less than 13 to 15 millimeters. When we want to use color and Doppler on the portal vein, we are going to switch to an intercostal position. When you put the color on the main portal vein, we expect it to be red or hepatopedal. You will want to turn on your angle correct for this interrogation because we will be measuring the velocity as well as evaluating for patency and direction. In the image here, we can see the main portal vein is being interrogated. We've got our less than 60-degree angle through here. We are just outside of the liver in the main portal vein, and we are showing normal above the baseline hepatopedal flow. Next, we will evaluate the left and right portal vein. For the left portal vein, you will use a subcostal view. Recall when you are imaging the liver in transverse of the left lobe, you start at the superior portion, you'll see the hepatic veins go by. The next part that you will see is the portal veins. So there is a portion of the left portal vein that travels directly towards the transducer when you're in the transverse subcostal plane. You will then put your spectral tracing in the middle of that portion that is coursing directly towards the transducer, and this is where you will be able to evaluate direction, velocity, and patency. So make sure that you do have your angle correct on for this image. Now to look at the right portal vein, we're going to go back to our intercostal window. Recall as the portal vein enters into the liver, it almost immediately splits into the right and left portal veins. So the majority of the portal vein that you can see within the liver is the right portal vein. You will find the best spot that is traveling towards the transducer. Again, this is typically red with above the baseline flow representing hepatopedal flow. You will also keep your angle correct on for this image as you will be evaluating direction, velocity, and patency. The last picture that we need to get then for our hepatic Doppler protocol is to evaluate flow within the main hepatic artery. You are again going to use an intercostal window. You're going to elongate your portal vein, and next to the portal vein, you should be able to see the hepatic artery running parallel with it. This is also going to be red. It typically has a higher velocity than the portal system does, so you might actually see some aliasing depending on how your color scale is set. Keeping that aliasing on actually brings your eye to where the hepatic artery is coursing, so it might be beneficial to leave the aliasing present. You'll keep your angle correct on to evaluate the hepatic artery as we will be assessing direction and velocity. All the pictures that you saw within the protocol do represent pictures that are of normal direction, of normal velocities. We just need to review again what some portal hypertension images do appear like. Remember that the cirrhotic liver is very common with portal hypertension, so we are going to see an echogenic, coarse, scalloped, edged liver, quite often surrounded by ascites. In the case of hepatofugal flow, we will see the portal vein being assigned the blue color, showing blood moving away from the liver. So this is the portal vein with hepatofugal flow. Next to it, you can see the hepatic artery coursing still into the liver, bringing that oxygenated blood. Measurement of the portal vein exceeding 1.3 to 1.5 centimeters does also indicate portal hypertension. This example here shows us a portal vein that is measuring 1.9 centimeters in the AP dimension. Remember that we take this picture typically from the subcostal plane. That is because we can create a 90-degree angle compared to our ultrasound beam, which gives us really nice walls to be able to measure this appropriately. You'll also want to use color and Doppler spectral tracing to evaluate any vessels that may have recanalized. This is an example of a recanalized ligamentum teres. When you are scanning through the trans left lobe images, instead of seeing the ligament teres as a bright echogenic triangle, you'll actually see either the absence of it or a vessel arising from that area. That is typically going to be your first clue that the ligamentum teres has recanalized. Definitely put color on that area, and in this example we can see the ligamentum teres traveling more anterior, and it takes a turn towards the umbilicus. Once a patient has been diagnosed with portal hypertension, there is not really any cure for the disease, but there are some interventions that we can do to help alleviate some of the symptoms and improve the quality of life for the patient. One of those being a paracentesis, where we drain the excessive ascites that is in the peritoneum. That can greatly relieve some of the discomfort that comes along with the ascites. However, a TIPS, or transjugular intrahepatic portosystemic shunt, can also be placed to help alleviate the portal hypertension symptoms. The TIPS is typically placed once a patient is at a greater risk for developing esophageal varices. If you recall from our previous lectures, esophageal varices are more susceptible to rupture, and when they do, a person can actually die very quickly from the hemorrhage of the ruptured esophageal varice. So the TIPS can be placed to alleviate those portal hypertension symptoms, reduce the likelihood of esophageal varices developing. When the TIPS is placed, it is usually placed through the jugular vein, so that's the transjugular part. The catheter is pushed into the transjugular vein, where it is threaded down through the superior vena cava, through the right atrium, and then into the inferior vena cava. Once in the inferior vena cava, the catheter then can be directed into the hepatic system. And it's through the hepatic system then, usually the right hepatic vein, that the shunt is placed and then connected to the right portal vein. Now, the whole point of this is that when blood comes in through the portal system, that it will travel through the shunt instead, connecting the portal blood flow directly to the hepatic veins, which can flow directly back into the IVC. This takes a lot of pressure off of the liver to accept all of that portal flow and redistributes it to the body to be cycled through at a later point. On ultrasound, the TIPS will look like an echogenic tube within the liver. Ultrasound can play a role in the evaluation for the pre-TIPS procedure. We are going to use our hepatic Doppler protocol to evaluate blood flow through the portal system and through the IVC hepatic system. We just want to make sure that everything is patent and that there won't be any complications due to blood clots or other abnormalities within the hepatic system. After the TIPS is placed, ultrasound is also used then to evaluate the success of the TIPS shunt. Again, we are going to follow the hepatic Doppler protocol to evaluate how blood is now flowing through the portal and hepatic systems. However, we also are going to take time to look at the shunt itself. We want to make sure that the shunt is still open, and we want to make sure that there aren't any clots or stenosis within the shunt. When you are performing a hepatic Doppler protocol with a patient that has a TIPS, it is important to remember that the right portal vein and the left portal vein are going to both show hepatofugal flow. So the main portal vein is still going towards the liver now with this shunt. The main portal vein brings the blood in, but instead of the blood flow going continuing hepatopedal into the liver through the right and left portal veins, those are actually going to be shunted down through the shunt. So we're going to see reversal of flow through the right portal vein and the left portal vein in a patient with a patent working shunt. Now, some failure signs that we might see with the TIPS is clot or stenosis in the shunt. So we might not see any color flow within the shunt. That would be a clot. Or we're going to see really elevated velocities within the shunt, suggesting a possible stenosis. When we are performing our hepatic Doppler, if we do not see reversal of flow in the right portal vein and the left portal vein, we also consider that to be abnormal, as the shunt is most likely no longer working. So here's an example of the echogenic tube within the liver representing the TIPS, transjugular intrahepatic portal shunt. So you can see the walls of the shunt. They're usually bright echogenic walls, and they kind of have this stripy pattern to them. While you're evaluating the TIPS, you want to make sure that it is completely patent. The portal side is usually going to be a little bit more medial, where the IVC side sits a little bit more lateral. You'll use color Doppler and spectral tracings to look for increased velocities and evaluate for patency. Here we are looking at the anastomosis to the portal side. Very normal, correct direction of flow. However, we begin to see abnormally high velocities on the IVC side. This is concerning for stenosis on the IVC portion of the shunt. And in this example, we have no flow coming through the portal system. I do want to point out again that this is not using the best physics. Remember, we don't get a Doppler shift recorded when we are 90 degrees to the ultrasound beam. So you do want to make sure that you're using correct windows, so we at least have some angle on the portal shunt to best evaluate the color flow through there. This example here tells us another indirect way that we can evaluate if the portal shunt is still patent. This first picture is immediately after the tips has been placed. What we can see in here is excellent flow through the portal shunt right here. And we're also seeing that reversal of flow through the right and left portal veins. So again, reversal of flow in the right and left portal veins is normal with a patent tips. However, 1 week after, patient is starting to have symptoms. We are no longer seeing flow through the shunt, and we see that the right portal vein has resumed its normal hepatopedal flow. So if you know a patient has a shunt and we're not seeing that reversal of flow in the right and left portal veins, that typically means something is wrong with the tips. And that brings us to the end of evaluating the portal system for vascular pathology. Up next, we're going to have a brief discussion about transplants.